When we are approaching the treatment for someone with mild to moderate Crohn's disease, we still have to take a holistic approach to the patient and understand what their primary symptoms are and also observe them for any evidence of progression. By a low-risk patient, we mean individuals who are less likely to progress to the transmural complications of stricture and fistula. And these are usually individuals with short segments of disease and what I consider to be superficial inflammation. They do not have the deep ulcers, but may have aphthous ulcers or cold sores or very mild local inflammation. These patients can respond to either non-systemic steroids such as budesonide. Some of these patients actually respond to mesalamine, and often these patients will respond to non-anti-inflammatory therapies, just symptomatic treatment such as antidiarrheals or antispasmodic treatment. Because these individuals have such a low risk of progression, we've also found that these are the patients who respond to placebo in controlled trials. The goals of treatment for Crohn's disease don't really depend on the risk. The goals are to, first and foremost, control symptoms which improve patients' quality of life. When we treat beyond the symptoms to mucosal healing, that's where we actually see longer-term impacts on patients, resulting in less surgeries, less need for hospitalizations, as well as long-term improvement in quality of life.
To treat patients with low-risk disease, we have a dilemma because we want to treat the disease adequately, but on the other hand, we don't want to overtreat the disease. And truthfully, we don't have a lot of different agents in our armamentarium that really are perfectly suited for low-risk disease. The analogy in ulcerative colitis would be something like the 5-aminosalicylates, which are good for about a third of patients with mild to moderate ulcerative colitis, but we don't have the equivalent kind of treatment in Crohn's disease. So therefore, generally what's recommended is if someone has low-risk disease, we might initially treat with budesonide with controlled ileal release. If it's ileal or right colonic inflammation, we may follow that up with azathioprine or mercaptopurine to sustain the response or remission. We might treat with prednisone if the disease is more extensive in nature. But always we're following up and trying to ascertain whether the patient actually did respond clinically and whether the patient had healing of the mucosa.
So I'm often asked what to do if someone's in clinical remission. Do you continue therapy? Should you so-called de-escalate therapy? My feeling is that the drugs we use in Crohn's disease, whether they're biologic drugs or steroids or immune suppressive drugs, have all been shown to not have a durable effect after the treatments are stopped. So they'll be effective for inducing and then maintaining remission. But if you withdraw therapy, you risk relapse. So my general approach, once I've identified a non-steroid drug that's effective in the patient, is to continue it for the long term, assuming that the patient can tolerate that. So another good question is when to step up treatment. And basically, my thinking about this is I want the patient to be in both clinical remission and endoscopic or colonoscopy remission. So if I have a patient that has persistent symptoms, I will evaluate them with some kind of objective measure. Sometimes it could be a biomarker like fecal calprotectin or CRP. More often it's going to be colonoscopy. And if at colonoscopy I see significant ulceration that would be compatible with the patient's symptoms, then that's going to lead me to step up therapy. And then it depends on what they're on. If they're on steroids, I'll probably go into some kind of biologic, usually in combination with an immune suppressive.